The abdomen is disinfected and draped after administration of spinal anesthesia and urinary catheter placement. In a repeat cesarean section, the scar is used for the incision, as shown in this case. Otherwise, the anterior superior iliac spines are marked, and the incision line is placed 3 cm under this level. After checking the sensibility of the skin is incised. The abdomen is opened with the Joel-Cohen technique, which is based on a minimum of sharp dissection with blunt separation of the tissues along the natural tissue planes. After the subcutis is opened bluntly, the rectus fascia is reached. 2 small transverse incisions are made in the fascia on both sides of the midline. The fascia is further opened by blunt digital traction. And the rectus muscle is separated, revealing the peritoneum. The peritoneum is opened bluntly as well. The demarcation between the bladder and lower uterine segment is pointed out. And the position of the fetus is determined. Then a transverse incision is made along the lower uterine segment. And the uterus and membranes are further opened with blunt digital traction. By moving the hand around the curvature of the fetal head and gently flexing it, the head is delivered. Oxytocin is administered intravenously to the mother. Lowering the drapes enables the mother to witness the delivery and initiate contact with the child. The head is flexed and the shoulders and rest of the body are delivered gently. Then the child is placed on the mother's belly, allowing contact between mother and child. The umbilical cord is clamped and cut. The child is assessed and handed over to the mother. This is the placenta, which is delivered with gentle cord traction. For intraperitoneal closure, the uterus is grasped with 4 clamps. An anchoring suture is placed at both ends of the uterine incision. Then the uterus is closed in one layer with a running suture. One additional suture is placed to stop this bleeding. It is not necessary to close the peritoneum and approximate the rectus muscle. And the next step is to close the rectus fascia with a running suture. An untied anchoring suture placed at the end of the opening on the surgeon's side may help during closure. It is removed at the moment the suture through the fascia is tied. This to avoid leaving 2 knots at this location that may lead to nerve entrapment. The subcutis may be closed with a few simple standing sutures. And the skin is closed with an intracutaneous suture. The placenta is inspected for completeness, which can be verified by checking that the membranes are present all around the placenta. The umbilical cord is inspected and has 2 umbilical arteries and 1 umbilical vein. This is the posterior side of the placenta with membranes all around it. If a hypertrophic scar of a previous cesarean section is present, it can be excised by incising both sides of the scar until the subcutaneous tissue. Then one side is lifted and the scar is excised at the level of the cutaneous and subcutaneous tissue. In a repeat cesarean section, the plane between the anterior rectus sheath and rectus muscle may be dissected sharply with a knife to avoid tearing of the muscle. In a repeat cesarean section, the apex of the bladder may have become adhered to the uterus to a level above the lower uterine segment. Under these circumstances, the bladder has to be dissected from the uterus. Meconium containing amniotic fluid is a sign of fetal distress. The meconium is shining through the membranes. The fetal distress is caused by the umbilical cord, which is wrapped twice around the neck of the fetus. Because it is so tightly wrapped, the cord can only be released after delivery. Exteriorization of the uterus can be helpful in case of severe bleeding, tearing, or a difficult exposure of the uterus incision. This is the uterine incision after repair. And in this overview, the uterus, fallopian tubes with fimbriae, and the ovaries. The uterus is placed back into the abdomen by pushing it dorsally and lifting the abdominal wall cranially. After completing the procedure, the skin can be infiltrated with a local anesthetic to reduce postoperative pain. Before starting the procedure, the following structures are identified: the rectum, the right adnexa, the round ligament, the ovary, the suspensory ligament of the ovary, and the external iliac artery, with the underlying vein. The first step is opening the peritoneum over the iliac artery with mobilization of the suspensory ligament, which can also be divided and ligated if needed. It may be necessary to remove some lymphatic tissue first in order to properly visualize the artery. Be careful not to damage or clamp the ureter. The external iliac artery and external iliac vein are clearly visible. The external iliac artery, external iliac vein, internal iliac artery, and their relation is pointed out here. The internal iliac artery is freed with the dissection forceps. Note the rotating movement of the forceps from laterocranial towards caudal medial. With this maneuver, the risk of damaging the internal iliac vein is minimized. A ligature can be placed in the clamp as soon as the tip is clearly visible. The index finger guiding the thread should be placed on the medial side and not between the artery and external iliac vein, to minimize the risk of tearing the internal iliac vein before it's draining into the common iliac vein. A similar procedure is performed on the left side.